Let's start with a patient scenario that I guarantee everyone listening has run into. It's one of the most frustrating disconnects in all of cardiology.
Mm.
You've got a patient in your clinic, let's say a 72-year-old, active, loves gardening, and they tell you they feel fantastic.
No complaints at all.
Zero. They're walking the dog, carrying groceries. They feel great. But you're holding their echo report, and the numbers are, well, they're screaming at you.
Severe aortic stenosis.
Exactly. We're
Wow.
talking a jet velocity over 4 meters per second, a mean gradient over 40. But this is the real kicker. Their left ventricular function is pristine.
Totally normal ejection fraction.
Normal EF, no wall motion issues. So you've got this critical anatomy, but the physiology seems normal, and the patient is just wondering why they're even there.
It is the classic clinical dilemma.
Uh-huh.
And honestly, it's one that keeps a lot of us up at night
Right.
because you are staring at a mechanical problem that you know will eventually kill them. But right now, they feel like they're living their best life.
Which brings us to the central debate we're really digging into today. Do you recommend early surgical aortic valve replacement SAVR right now while they're asymptomatic?
Or do you stick with the traditional approach, the watchful waiting?
And the stakes here are just incredibly high. We're not debating starting a statin or adjusting a beta blocker.
This is cracking a chest. We are
Yeah.
talking about open heart surgery in a person who insists they feel healthy.
And that's the terrifying part, isn't it?
It is.
You don't want to be the clinician who pushes for surgery on a patient who feels fine, only for them to have, say, a perioperative stroke or a bad wound infection.
You've essentially taken an asymptomatic patient and made them very, very sick. It's the ultimate error of commission, the nightmare scenario.
But on the flip side, we have to ask ourselves, by waiting, are we making an error of omission?
That's the question. Are we missing the window? The one spot where surgery actually buys them more life? That's the tension we need to resolve.
Okay, so let's start with the status quo. Because if we're being honest, the default instinct for most clinicians, and definitely how I was trained, is watchful waiting.
Oh, absolutely. For decades, the dogma has been, if the patient has no symptoms and the LV function is preserved, you sit tight.
Just monitor them.
You monitor them like a hawk, maybe an echo every 6 to 12 months, but you do not cut.
And the rationale was always, first, do no harm.
Right. It's risk aversion, plain and simple. I mean, historically, the logic was that the risk of sudden cardiac death in an asymptomatic patient was really low.
Less than 1% a year.
But 20 years ago, the risk of dying on the operating table for that same surgery was higher than that. So the math was simple.
The surgery was more dangerous than the disease.
In the short term, yes, the surgery was the bigger threat.
But that logic, it assumes that watchful waiting is sort of a neutral act, like the heart's just in a holding pattern while we wait.
And that is exactly where our understanding has shifted, massively. We now know that watchful waiting isn't benign at all. While that patient feels fine, their heart is struggling against a huge pressure load. It's facing severe afterload mismatch.
So the heart muscle is thickening up, it's getting stiffer.
Exactly. You're developing hypertrophy, but the really bad part is you're developing diffuse myocardial fibrosis.
Scar tissue.
That's right, scar tissue. And once that fibrosis sets in, it's often irreversible. So
Yeah.
even if you replace the valve later when they finally get symptomatic, you've already put a permanent ceiling on that patient's long-term survival.
So we're essentially letting the heart kind of rot from the inside out while we wait for the patient to admit they're short of breath.
That's a visceral way to put it, but that's the core of it. We're shifting the goalposts. The question used to be, how do we prevent sudden death?
I know.
Now the question is, when is the optimal time to intervene to maximize their life expectancy? It's a move from symptom management to life extension.
And this isn't just theory anymore. We have actual randomized data on this. The recovery trial, the Avatar trial.
Right. And these trials were game changer. They finally moved us beyond just observational data. You look at the recovery trial. It was in the ENJM. They took patients with very severe aortic stenosis.
And just to clarify for everyone listening, when you say very severe, what were the criteria there?
They were looking at a peak velocity of 4.5 meters per second or higher. So really tight valves.
Okay.
They randomized them to early surgery versus conservative care. And the results were, they were striking. The operative mortality in the surgery group was effectively zero.
Zero.
But the long-term cardiovascular death rate was significantly lower compared to the watchful waiting group.
So the bottom line is the early surgery group lived longer.
Significantly longer. The hazard ratio was just heavily in favor of early intervention. And the Avatar trial, it showed similar results in a slightly broader group of severe AS patients.
Okay, so the data signal is pretty clear then. Early surgery saves lives. But I want to pause on something you just said. You mentioned that in the recovery trial, operative mortality was effectively zero.
I see where you're going with this.
Well, as a clinician, I hear that and I think, wow, that's amazing. But then I look at the real world data from hospitals across the country, and operative mortality for SAVR isn't zero.
Not even close.
It's usually closer to 2%, maybe even 3% in lower volume centers.
You have just hit on the single most important caveat in this entire discussion. If you miss this point, you are going to hurt people.
Okay.
This recommendation for early surgery is entirely
Conditional.
conditional on the center's expertise. Precisely. The math of early surgery only works if the immediate procedural risk is rock bottom. You're betting long-term gains against that immediate risk.
Can you walk us through that trade-off?
Sure. Think about it. You have an asymptomatic patient. Their risk of dropping dead in the next year is maybe 1%.
Okay.
If you send them to a hospital where the surgical mortality rate is, say, 4%, you've just quadrupled their risk of death in the first week. You've completely wiped out any potential long-term benefit.
So this is not a blanket recommendation for every community hospital or every surgeon out there.
Definitely not. The guidelines, the trial authors, they're all very specific about this. Early surgery should only be recommended if it's done at a heart valve center of excellence.
You need high volume.
Low mortality, ideally less than 1%, and high expertise across the whole team.
That puts a huge amount of responsibility on us, the referring physicians. We can't just write refer for SAVR and send them to the nearest surgeon.
You have to know your system, you have to know their numbers. If you don't have access to a center with less than 1% mortality for isolated SAVR, then watchful waiting might actually still be the safer choice for that specific patient.
That is a critical distinction. So the equation is early SAVR is superior if, and it's a big if, the surgical risk is negligible.
Correct.
So let's talk about the patients themselves. Even if we have a fantastic surgeon, are there patients who still shouldn't get early surgery? Who do we exclude?
The biggest exclusion group would be the frail and those with significant comorbidities.
Why is that? I mean, if the valve is the problem, shouldn't we fix it regardless?
Because surgery is a massive physiological stress test. We call it the stress test of life.
Right.
If you have a patient who is frail, has severe COPD, or maybe just has a limited life expectancy from other causes, the preventative benefit of fixing that valve early it's just negligible.
Because they might not live long enough to actually reap the rewards of protecting that heart muscle we talked about.
Exactly. You're putting them through the trauma of surgery, the pain, the rehab, the risk of infection, for a payoff that's 5 or 10 years down the road. If they don't have 5 or 10 years, you haven't helped them.
So in those cases, watchful waiting becomes the gold standard again.
Yes. For frail patients, you wait until they are clearly symptomatic, because at that point, you're not operating to extend life, you're operating to relieve suffering. The entire goal of the surgery changes.
Okay, now let's pivot to a gray area that I find really tricky. The asymptomatic patient who might not actually be asymptomatic.
The unconscious adaptation. This is huge.
Right. You ask them, do you have shortness of breath? They say no. But then you dig a little deeper and you find out they stopped taking the stairs 2 years ago.
Or they nap every afternoon. Patients with chronic valve disease are masters of autoregulation. They just flatten their lifestyle to match their cardiac output.
So they don't even realize they're symptomatic because they never push themselves hard enough to feel it.
They just chalk it up to getting old.
So how do we verify that? Because if they are actually symptomatic, then this whole debate about early surgery is moot. They just need surgery, period.
Correct. Symptomatic severe AS is a Class I indication. Do not pass go. To unmask these patients, you have to use exercise testing.
Put them on the treadmill.
Yes, a standard Bruce protocol. It is probably the most underutilized tool in this whole population. The guidelines strongly recommend it.
Okay.
If you put a supposedly asymptomatic patient on a treadmill and they get winded at 4 minutes, or their blood pressure drops, or they have arrhythmias.
Then they aren't asymptomatic.
Exactly. They're pseudo-asymptomatic. And the data suggests about a third of patients who claim to have no symptoms will actually fail a stress test.
A third? Wow, that's a massive number.
It is. So right there, for 30% of these difficult cases, the decision is made for you just by ordering a simple stress test.
That's a really high-yield takeaway. If you're on the fence, stress them.
Always. It clarifies the physiology.
Let's talk about some of the pitfalls. We touched on surgical risk, but what about on the diagnostics side? I feel like we often get really fixated on the numbers on the echo report.
That is the trap of treating the echo instead of the patient. You see a high gradient, maybe 55, you panic. You rush to recommend surgery, but you have to correlate it. Was the patient hypertensive that day? Was it a high flow state?
So don't base a major surgical decision on a single data point.
Right. Verify the severity. And another major pitfall is the setting. Most of the data supporting early surgery comes from stable outpatients.
As opposed to the inpatient consult we all get.
Exactly. We all get that consult. Patient admitted for a hip fracture, echo shows severe AS. Can you clear them for surgery? Or should we fix the valve first?
That is a totally different physiologic state.
It's a different universe. That patient is acute,
Yeah.
they're inflamed, stressed, maybe fluid overloaded. You cannot apply the early intervention evidence to that patient.
Right.
That's not an elective preventative scenario. You manage the acute issue, you stabilize them, and you reevaluate the valve in the outpatient setting when they're back at their baseline.
That's a really important distinction, acute versus stable. What about biomarkers? Everyone loves a BNP or a troponin. If I have an asymptomatic patient but their BNP is 300, does that push me to operate?
Maybe we sure were that simple. A magic number would make our lives so much easier. But the current evidence just doesn't support using specific biomarker thresholds as a standalone trigger for surgery.
So we can't just say BNP over 200 means cut.
No. It adds to the clinical picture. If you see the BNP rising serially over 6 months, that's a red flag. It suggests the ventricle is under strain. But you shouldn't operate solely because of a number. It's too nonspecific.
Okay.
It needs to be part of the holistic view.
And I want to touch on the patient's voice and all this. I mean, we are talking about prophylactic surgery. That is a hard sell.
It is. You are essentially telling a person who feels fine, I want to hurt you now to help you later.
I want to perform a major intervention with a 1% risk of death so you don't die in 5 years.
And some patients, when they hear that trade-off, will say, no thanks, I'll take my chances.
And that's a valid choice.
It's a completely valid clinical decision. We can be paternalistic here. Some patients prioritize their present quality of life over potential future longevity.
And if they refuse, we go back to watchful waiting. We haven't failed. We just continue to monitor them.
Exactly. It's shared decision-making. But our job is to make sure they understand that doing nothing is actually an active choice with its own set of risks.
So let's try to synthesize all this. We've covered the history, the new trials, the huge caveats about center expertise, stress testing. If we're advising a colleague with a full clinic tomorrow, what is the consensus summary?
The consensus has definitely shifted. 10 years ago, the default was wait. Today, the safest default, provided you have the safety net of an expert center, is leaning toward early surgery.
So we're moving from a reactive model to a proactive one.
That is a perfect way to frame it. We're preventing the crash rather than cleaning up the wreckage.
We talked about having a sort of a one-line rule to keep this actionable. How would you phrase the heuristic for this patient population?
Okay, here it is. In asymptomatic severe aortic stenosis with preserved LV function, recommend early SAVR at an experienced center unless specific red flags exist.
And just to recap, what are those red flags again?
The red flags are frailty, significant comorbidities that limit life expectancy, a lack of center expertise or high surgical risk, or, of course, patient refusal.
It really flips the script. Instead of looking for a reason to operate like symptoms, you're now looking for a reason not to operate.
Exactly. If you can't find a valid reason not to operate, and you have a great surgeon available, you should be having that conversation with your patient.
It really changes how you look at that echo report. You stop sighing with relief that the EF is normal, and you start to worry that you're missing the window of opportunity.
That's the burden of knowledge, but it's also the opportunity. We have the tools now to really change the trajectory of this disease.
It makes me think about the direction of cardiology in general. We seem to be moving toward this model across the board, treating the anatomy before the physiology completely fails.
It's true.
You see it in EP with early ablation for AFib. We're seeing it here with valves.
It is the future of medicine, I think. We're getting better at predicting risk. The challenge for us as clinicians is having the courage to act when the patient in front of us looks well. It feels counterintuitive to intervene on a well person.
But the data is telling us that waiting until they aren't well is simply waiting too long.
Precisely.
So here's the clinical application for everyone listening. Go back and look at your patient roster. Look for those watchful waiting patients with severe AS, the ones you've been high-fiving every 6 months because they say they have no complaints.
The stable ones.
Right. And ask yourself, why are we waiting? Is it because they are truly frail? Or is it just habit? If they're fit and you have access to a top-tier valve center, send them for a stress test. You might be missing the window to buy them an extra decade.
Reevaluate the strategy. Don't let do no harm become an excuse for doing nothing.
Until next time.